my man maputa oboroge kwelugodi na nyi kunoku na puoku go easy na water when we dey spend no mercy it's the journey for a golden beauty makana men usike
football is been seen to be a subset of equity. And dwelling on the definition of policy being a gap to determine the present and future decision, as well as statements that relate to decisions that have to do with medicine in a country. Pharmaceutical policy has been known by several clients to be taking after to take a view after what the WHO decides to follow. National drug policy has been taken to be pharmaceutical policy. But at the same time, whether it is called pharmaceutical policy or drug policy, there are several other drug policies that could be named or called pharmaceutical policy outside the national drug policy. What I'm trying to establish is the fact that by the WHO definition, pharmaceutical policy is predominantly geared at national drug policy. Whereas there are other policies that are pharmaceutical policies that are related or tangential to national drug policy. I'm laying this foundation so that when we move on, I will not be seen to be controversial. If you want to dwell on the national drug policy, the philosophy behind that has to do with equitable access to and rational use of essential medicines that are safe, efficacious, affordable, and of good quality. And that is what National Drug Policy 2021 preaches as a goal, and from there the objective derives. The next slide. Definition of terms. Regulation. Regulations are authoritative rule. They give order, or they are orders that are issued by government agencies, and their subsidiary legislations. And I'm glad we are putting the two concurrently. I want to differentiate between policy and regulation. While regulation is a subsidiary legislation, policy is not. What policy does from our first regulation is to give a guide. And to give that guide, there will be a statement. And for pharmaceutical policy, it has to be related to medicine. For legislation or regulation, subsidiary regulation is a subsidiary law. Regulations are subsidiary legislation. They give authority, rules of authority, and they have the power of compulsion. We are compelled to go by it because they are laws. Why policies are just guys and they are drafted in the form of a statement? That is the difference between the two. We'll be using the two as we move along the line. The next slide. I don't need to go into details when it comes to this. In a low resource setting, we know there is bound to be poverty, inadequacy of social and infrastructural amenities. And with that, there's going to be poor services in terms of health, education, and so on and so forth.
Pharmacist Lukweju told us about policy, what policy is all about. He also talked about regulation. He tried to differentiate between the two. And of course, he went further to tell us about pharmaceutical policies. And he tried to narrow them down to national drug policy, national essential medicine list, and all that. Then, of course, he told us about the policy development process, where you put together your thoughts, you implement at the end of the day, and of course, you follow up with monitoring and evaluation. He also talked about the national drug policy. He narrowed everything down to the national drug policy, told us about the objectives, and of course, he talked so elaborately on the strategies for implementation of pharmaceutical policies in the country. He also went further to tell us hindrances, and he concluded.
My name is Dr. Danjuma Oyinakababa. I'm the Director, Health Planning Research and Statistics, National State Ministry of Health. I would like to ask you, in relation to what you've presented to us, where is the position of pharmacy in the current swap agenda of the Federal Ministry of Health, the sector-wide approach? Where is the position of pharmaceutical policy in relation to the current agenda of the Federal Ministry of Health, the sector-wide approach, codename SWAP? Because one of the pillars of the SWAP is talking about unlocking the value chain. So, in relation to your presentation, where is the position of pharmacy in relation to that agenda? And secondly, the push, I will recommend that the council should push more to ensure that one of the strategies you presented to us in ensuring that the states and the federal institutions located in the states align themselves to those distribution centers, the DMAs, so as to prevent this PPP from eroding or encroaching into our practice. Thank you.
Thank you very much. I hope you got the questions. Okay.
Thank
Next.
you very much. My name is Dr. Kingsley Amibo. These days, there's a lot of agitation, a lot of complaints from pharmacists, especially on the social media platforms. Pharmacists are complaining that PCN, they're accusing PCN of under-regulation of the sector. You see patent medicines shops springing up all over the place. Anybody has access to any kind of medicines, including the battery poisons and all that. Some time ago, I was opportunity to be in Ghana, Accra, for a program. And then I developed diarrhea, and because of that program, running stomach, very severe. And I approached a community pharmacist, a premise for simple, basic anti-diarrheals like Flagyl and tetracycline. And I was asked to go to the hospital and see a physician and procure a prescription. That there, they don't sell medicines to people without prescription. And that's a low resource country. I'm talking about Ghana. So we hear of challenges and all that with PCN, but we are concerned about how long are we going to put up with the current situation or current. There's a lot of frustration and, like I said, agitation for change. So can you give us an assurance, probably a timeline on when we can expect some remarkable progress as far as regulation is concerned? Thank you.
My comment and question is on the PPP that you talked about, and I'm aware the PPP has the PCN has a PPP policy, and the PPP policy from PCN ought to have addressed the challenges we are facing now. So my question is, what is the PCN doing to improve the review of that policy and take care of this challenge we are facing? Because the real situation is far beyond, as you have stated, because the heads of federal health institutions use that advantage to circumvent the processes. So that's just my question. Thank you.
Thank you. Review of PPP document from the PCN.
Thank you. My name is Pharmacist Mfono Wongokon. I want to commend you for a scintillating presentation. I actually have two questions for you, sir. Because you speak about pharmaceutical policies and regulations. And we're talking of equity in pharmaceutical care. We know the majority of health consumers are in the rural areas, and we have drug policies, we have medicines policies. That's about the product. I'm asking you, what's your thought? My first question on when you talk of distribution of medications to undeserved communities, but our policies don't speak to the personnel that is going to give this pharmaceutical care at those rural areas. Can we have quality pharmaceutical care? We will just focus on distribution without the personnel, because we have the Pharmacy Act that says that wherever drugs are dispensed, you must have a pharmacist, a superintendent pharmacist in charge. But in the rural areas now, how can we, as pharmacists, because you talk of laws being paper tigers, work so that this act does not become a paper tiger in that regard? So you can have pharmacists in rural areas, primary health centers, dispensing drugs. And when we come to meetings like this, we can actually have pharmacists from primary health care centers being part of AHAP. That's one question. Two is that you talk of a policy that is incubating, the prescription policy. I know that there's a topical issue now about pharmacist-initiated prescriptions of medicines, and it still correlates with equity, because when you go to rural areas, you might have pharmacists there, but no doctors. This is your guideline now that is in the embryo. Will it speak to pharmacist-initiated prescription, that pharmacists can have? There will be protocols that pharmacists can prescribe some certain range of medicines,
okay, which
will be of very great importance to undeserved communities.
Thank you.
That's my question, sir.
My name is Pharmacist Sulaiman Abdusalam from Osun State. I'm speaking here on behalf of my HOD, who is the Director of Pharmaceutical Service Unit of Osun Children's Hospital. He told me to ask a question that in regard to the implementation of pharmacist consultancy cadre, he told me to ask a question that can't we employ or adopt an industrial action to achieve that aim? Because the reason why I'm saying that was that implementation was done in our units. After engaging in meaningful meetings, there was no result. Then we had to resort to an industrial action, and it yielded. So they have to compromise their resistance to that program. And by God's grace, there is a lot of progress in that regard in terms of practice and remuneration. So he asked, why can't we adopt that strategy nationwide?
Okay, thank you. The last person on the row.
I am pharmacist Kolawole Ekujumi. I'm the Director of Traditional, Complementary and Alternative Medicine Department in Ondo State. The department was established 2 years ago. And from the lecture, I discovered you said we have about 70% of the country medicine consumptions are imported. And we have zero tariff on pharmaceutical raw materials. I've been privileged to work with 2 production companies before moving to civil service in Ondo State. And I discovered corn starch, cassava starch. These are raw materials we can source locally. PSN can be on the forefront of training some pharmacists in the area of getting corn starch and some of these excipients. We can sponsor some of us to go into it. And I discovered recently a colleague of ours, when we did World Hepatitis Day, he mentioned that he had the local products that can manage hepatitis, and some doctors were buying into the product. So it's time we don't leave these traditional medicines in the hands of illiterates, people that are not well learned, because most of them that registered under Alternative Medicine Board recently, 2/3 of them had primary school as a primary entry point. And cognosy is a core course in pharmacy. Please, I want all of us to begin to look inward, and the PSN to be in the forefront to ensure that some of us will go through training in production of some of these excipients like corn starch and cassava starch, and even
sucrose. So this is one area I want us to begin to pay attention to, so that in some few years we can take over that local content and benefit a lot from it. Thank you very much.
Good afternoon, everyone. You're welcome to the second plenary session of the 26th AHAPN National Scientific Conference of our great association.
I want to welcome all of us to this session. I know that this session is one that many of us have been waiting for. I want to especially appeal to us as pharmacists, and particularly to our chairman. I think the time for lamentations are over. Let us stop lamenting. It's time for action. So I'd like to ask you, if you can just form a think tank, people will be thinking on our behalf. Give us strategic thinking, strategic thoughts. Let's see whether we can walk the talk. We have done so much in the last couple of years. In 2004, 2005, AHAP wasn't like this. But today we are happy that we are growing. Pharmacists are not the poorest of all the professionals. We're only asking for more. We already have the minimum. We're only asking for more. So we should stop this attitude of what you call self-de-recognition. There's nowhere. We are good people. We are noble people. Let's stop lamenting. Let us see how we can talk the talk. On the issue of PPP, that thing can be stopped too. It can be stopped. Go and read the books very well. No hospital can do PPP unless the user department agrees. It's there in black and white. PCN also has its own regulations, and it's captured in the Act of 2022. It's captured there. So nobody should think that if you rise up, somebody is going to say no. No, there's nothing like that. This is the Federal Republic of Nigeria.
In Nigeria today, we have what we call pharmacy laws and drug laws based on 1921 of Part 1 in the second schedule. If you're talking of pharmacy laws in Nigeria, and I will give you a rundown because pharmacy practice is laden with very substantial antiquity when it comes to legislation, and you see that as we go on. There are two major pharmacy laws now in Nigeria. The one we will review extensively, which is the most potent, that is the Pharmacy Council of Nigeria Act, Establishment Act 2022. And then we still have the Poison and Pharmacy Act 535, Laws of the Federation 1990. Those are the only two substantive pharmacy laws existing in Nigeria today. Every other pharmacy law has been repealed, and I will show you examples of some recent ones that were repealed within the context and framework of this existing PCN Act 2022. In 1902, I just want you to see the significance of this. You know, we started in 1878. That law affected only Lagos Harbour operations, but the 1902 ordinance was broadened and it was extended to places, coastal areas, where there was high maritime activities. If you look at the list you have on that slide, you see names like Warri, Opobo, Calabar, Escravos. These were areas where you had very high level marine activities. And so there was a need for the governor in council at that time to expand that regulation to those places because drugs were coming. From 1902, I won't go into details again, but we had new ordinances in 2023, 2027, 1936, and then strategically 1958. The only reason I'm going to give you information about Cap 152 of 1958 was that in 1958, the ordinance in 1958 gave birth to what was then Pharmacists Board of Nigeria. Significantly, that was when pharmacy became an autonomous profession in Nigeria, because that was the first time we had the entire membership being pharmacists. And this was amplified by Act number 26 of 1964. Of course, all of these laws that I'm talking about have been repealed. The metamorphosis of these laws, the 1964 version, is actually what you have in today's Poison and Pharmacy Act, CAP 535, Laws of the Federation 1990. I hope I'm communicating. Okay. Section 2 of the law. For the very first time since 1958, and that's what I want you to see here, there was a significant amendment in the composition of our council, because you now have a section 21I that gives room for the inclusion of pharmacy technicians, 3 pharmacy technicians of not less than 10 years standing. 3 pharmacy technicians. So it's the first time non-pharmacists will be members of our council. The reason, anyway, I'll go to the reason. Then, of course, the registrar of council is today a member of council. Hitherto, the registrar was only secretary. Was only secretary to council and secretary of the disciplinary tribunal. But today is a member secretary, is also CEO, as you will see as we go on, of council. Then, for the first time, we have also brought the DG NAVDAC in section 21K as member of council. Now, what are the benefits? I try to give you the justification for this. The justification for this is simple. If you regulate the life and destiny of a people, like technicians, who have also become a lot more sensitive to their rights, to agitate for privileges, the best way to carry them along is to give them some sense of belonging, and that's what section 21I attempts to do. With regards to the registrar, I've been a member of that council a number of times. You know, because the registrar was never a member of council, he never had a privilege to participate at plenary. He could only listen and take notes because he wasn't a member. Now, what this law does now is that the registrar can influence decisions from plenary because he's now a member. He's a member secretary.
Pharmacist Olumide can never disappoint. And I'm happy that he opened our eyes and our minds to where we should direct our efforts. I'm sure that many of us do not even know that Pharmacy Act 2022 exists. It is something you can download and put on your phone. And if you want to go a step further, print it. Take time to read 1 paragraph per day. Before the end of 1 year, you will have read everything. Because I think that is one of the problems we have. We hardly read. And that was why I started by saying, let lamentation give way to actions. We have reached this stage where we begin to challenge this, and that is why my talk and do chairman, I want to really appreciate you. Because we have done a lot of things in the past, and we have challenged a few things, and we have gotten results. Even at the level of comfy and all of that, I've challenged a few things and we've gotten results. The 32,000 that is being enjoyed today as the hazard allowance or whatever, it was because we challenged the situation. And we were there when the negotiations were being made.
Good afternoon, colleagues. My name is Stephen Ojumosu, PhD. And thank you, Pharmacist Olumide. That's my middle name too, Olumide. Now, I have 2 questions. And these two questions border on sections 31.1, section 31.1, and section 27.1. Section 27.1 says that only pharmacists shall own retail or community pharmacists. And section 31.1 also gives the power to enforce that, which means only pharmacists, only registered pharmacists shall be inspectors of those outlets, right? Okay, so we cannot be coming here every year, do conferences, have 3 letters, organizations like PSN, PCN, and not still act and be toothless dogs. My question is this: if only pharmacists can be inspectors and only pharmacists can be owners of retail pharmacies. I want you to answer two things. One, what is ownership? Is it just by including a registered pharmacist in the board of directors of the ownership? Or is it 51% of owning the business? Or is it 100%? What is ownership? Number two, if pharmacists are the inspectors, at the point of registration, at renewal, and going forward, why is it that we still have pharmacy stores owned by non-pharmacists?
I have two questions. First and foremost, regarding the idea that gave birth to PMS existing in our practice. PMS, that's the patent medicine vendors. Okay. Do we still need PMS or patent medicine vendors in our system, given the state of advancement that pharmacy practice has gotten to this year? Then, secondly, concerning section 22, 29, and 33, which speaks so much, 22, 29, and 33, which speaks so much about hospital pharmacy regulation and the fact of having SP-related pharmacists and the PCN having the right of law to regulate. I'm really concerned about our private hospitals as of today. Please, I know you are not from PCN, but I want to really understand what's going on and how.
So I am just still Dr. Solomon Kedechiwafo. I want to ask a question. Is seniority still important in hospital pharmacy practice? If seniority is important, that means there is a confusion in section 29 of our constitution, which emphatically stated that there will be a superintendent pharmacist. That means there is total erosion of seniority. Thank you. I don't want to go further.
Thank you. There shall be a superintendent pharmacist.
No seniority.
Who shall be?
Good afternoon, colleagues. My name is Dr. Obiko Yaladi. I will start from the last one. The 2022 Acts emphasize any public pharmaceutical premises must be registered. Must it be by a senior pharmacist like the asked? Because that is causing a lot of confusion in our systems today. The second thing is when you look at section 64, it talks about regulation, rules, and guidelines, which must be approved by the minister. Section 64 subsection 1 says that any new guideline or regulation must be approved by the minister, who incidentally is a legis, which means, which I know, that some of the gains of the COVID has been eroded. So we'll look at that. And then lastly, when you look at the Pharmacy PCN Act of 2022, it was only in one place that clinical intervention was mentioned. Are we shying away from it? Now we are moving from product-oriented system to a patient-oriented. We don't emphasize in our license. Thank you.
Hello, distinguished colleagues. We'll be taking the last plenary session, the future of hospital pharmacy practice, navigating the intersection of healthcare delivery and technology.
Now you will understand that the way the profession developed, we started off by manual compounding and then dispensing. However, if you look around you, technology has developed a lot. So because technology have developed so much, there is the need to integrate these new technologies that are in our environment. There is the need to integrate them with what our professional skills have empowered us with. So in order for us to carry out that kind of integration, in order for us to be able to carry out that kind of integration, we need to first of all list out these key technological innovations that are in our environment, understand what they are, and see those ones we will be able to carry their advantages, marry with our own skill sets in order to improve patient safety and patient care. So what are these technological developments? that is happening all around us. One of them is automation and robotics. Now, automation and robotics, we have seen videos of machines moving around, carrying one thing or the other, or carrying one activity or the other. We have seen them assembling cars. We have seen them changing their own batteries. So, how can this come into healthcare? And what can they really do for us? We'll have that discussion today. We have heard about artificial intelligence and machine learning. When we talk about artificial intelligence, we are looking at inanimate objects able to carry out specific actions that are only associated with biological entities. We are looking at inanimate objects being able to act as if they can think on their own and make decisions that are equivalent to that of an expert in a specific field. Now, when we talk about machine learning, it is a subset of artificial intelligence whereby we can present some facts, some information to a non-biological entity, and it can learn from those facts in such a way that when we now present information that has not been previously exposed to the non-biological entity, it is able to take decisions that appear to be as if it is an expert in a specific field. So that is machine learning. Now, neural networks play a strong role. When we talk about neural networks, you will remember the cells in your brain, the neurons. That was what gave inspiration to the development of large language models. These large language models are what we are actually now using as the brain, the engine room that help softwares like GPT to be able to act as if they can think. So the technology actually borrowed from the neurons of the brain. So that is where artificial intelligence and machine learning drew inspiration from. We'll look at telepharmacy, okay, and remote pharmacy services, whereby those who are in rural areas who may not be able to access pharmacists who are located outside those rural areas will be able to get services, okay, in such a way that their prescriptions can be accessed and the dispensing of those prescriptions can be approved by a qualified pharmacist.
So what the prof has actually told us that we are in the era of AI, which is very beneficial, and that we need to really delve into it, to read more about it, and then begin to accept the realities that in future, AI probably might take over some of our functions, and that, of course, some of us might have not had the opportunity of even seeing robots, but we must have seen it on the internet, where you see robots dispensing drugs and then taking the medication directly to a patient that is on admission. And all these are automated, that it gives us precision, and also you find out that the time lag for you to count out or to bring out the drug from the shelf for the patient is also limited. And of course, in everything, there is always an advantage and disadvantage. Of course, the advantage of it is that, yes, there will be better management of time, but in the overall. But if you look at the advantage, you find that the cost of training, even to buy even the equipments at our hospitals, will be very enormous. But it is good that at least we are now informed that maybe in the advanced world, some of these things are already taking place. And then we should bear our minds that when some of these things are being introduced into our facilities, we should not see it as if our roles are going to be taken over. No. It is rather that it will improve our efficacy and, of course, the precision in whatever we do.
Please, in my own facility, I work at the primary healthcare level. So, because, since primary healthcare level, we have areas that are remote areas. Then, luckily, I would say in Lagos, we now have what we call health districts, created out of the primary healthcare board. So I would say I'm lucky. I'm one of the directors of the health districts in Lagos State now. So my permanent secretary, she started telemedicine in some of our primary healthcare centers. So we started telemedicine in some of our centers. But since in those centers, we don't have enough pharmacists. So the doctors interact with the pharmacy technicians. But with what you said now, I want to go back home and tell her that the patients can, if it's possible for the patients to interact with pharmacists, because we have pharmacists that supervise those pharmacy technicians. Though I don't think it's AI we are using for. Is it AI? Will I say it's AI we have?
Yes, you can use video cameras.
Okay.
Yes. So you see them, they see you, yes. And you can talk to them, they can ask you questions and you can reply to them. Just as you do video calls.
I read that AI can lead to as much as 60% of that introduction of AI into the health sector can lead to as much as 60% of job loss for pharmacists. And of course, what that translates for pharmacy technicians. Naturally, they will just be phased out. So I would like to share your views on that. Do you support that view? And then, secondly, develop climes where energy supply is constant. Of course, the concept will work perfectly well. But Nigeria being a resource-constrained country where it's no regular light and all that, I'm not sounding pessimistic, but I think that the AI concept might really take some time before it takes shape in Nigeria and other resource-constrained countries for reasons like I just mentioned. Thank you.
Okay, my name is Chofu Agada from Cross River State, practice in Calabar, Cross River State. I want to first of all appreciate you and thank you for the lecture that you have delivered. We have gained a lot. My concern borders on one of the challenges mentioned that has to do with huge funding. And one of the things you mentioned is the interoperability and health information exchange. Like those of you that are expert in this area, whether we like it or not, before you know it, the reality of what we are discussing today, we'll see it. So the experts in it, those in Nigeria, in a resource-limited environment like Nigeria, I don't know whether you are putting your heads together such that challenge of push funding can be overcome by seeing how institutions can collaborate in terms of health information exchange and interoperability. So I don't know if people are already putting your head together to ensure how maybe you can do advocacy to institutions to collaborate so that we can see the reality sooner than we think in our environment. So I don't know whether it is something like that is ongoing already. Thank you.
Heavyweight men, no be normal men. Men with so many sources of income. Movement.
Men wey get money, they know they do cha. You know your nigga full evidence. I go lie for you. If you hear we want. You know say na men they bunny. It's money movement, you're nothing. Men will wait.
Heavyweight though, no
cha.
Make money lift up.
It's money movement, you're nothing. It's money movement, you're nothing. Men will wait.
Heavyweight men, no be normal men.
I go lie for you. It's money.
Pillar of Support Award. The first one goes to Sam Pharmaceuticals.
No cha-cha-cha. No cha-cha-cha.
Pillar of Support Award to FitSyn Healthcare PLC. FitSyn.
It's money movement, you're nothing. It's money movement, you're nothing. Men will wait, if you wait, oh. Men will wait, I go lie for you. It's money movement, you're nothing.
My men are billionaires, go and verify.
Les no men